a lot of us here are clinicians, and at the end of the day, whatever we talk about has to really be relevant in a clinical setting. So I thought that I would introduce a patient case here. So this is a real-world prostate cancer patient. This is not a patient that will be recruited to a clinical trial, but this is the patient that I take care of in my clinic, and you're more likely to encounter in your own clinical practice. And this is what the HPI often summarizes as. So our patient here is a 72-year-old obese male with diet-controlled diabetes, hypertension, a questionable TIA that's not well described, dyslipidemia, a coronary artery disease, and he had PCI for an inferior myocardial infarction 1 year ago, who presents for follow-up. Now, I'm lucky that I work in a cardio-oncology setting, and so I would know that this patient has prostate cancer and their intended therapy, or what is their past oncologic therapy. But most of the time in a community setting, you will see somewhere buried in their past medical history, just above hiatal hernia and just below arthritis, you will find somewhere buried in there is that the patient has or had prostate cancer. And when you scan the med list, and if you do that very carefully, you will see that he is now on Lupron. And more than that, we oftentimes don't have any more information than that. Now, that being said, I would like to say that this patient really does represent the real-world patient. There was a very nice, very simple study from Canada earlier this decade, 2011, 2012, and it was a study of 100 consecutive patients. These were patients that had prostate cancer, were going to undergo combined ADT and radiotherapy with curative intent. These patients underwent, they did a very thorough chart review to determine the prevalence of metabolic and cardiovascular risk factors, the prevalence of cardiovascular disease itself, and in patients without evidence of pre-existing vascular disease, they calculated the Framingham risk score for all these 100 patients. And what they found might sound astounding to some of our non-PCP, non-cardiology colleagues, but certainly rings true to me, which is that more than half of these patients were hypertensive. The same held true for dyslipidemia. 1 in 5 almost had diabetes, and about 17% of these patients had pre-existing coronary artery disease. 5% had peripheral arterial disease, and 7% had had a stroke. So overall, what is seemingly a very, very high-risk population is probably the norm for patients that go on to develop prostate cancer. Now, in these 100 patients, only a grand total of 4 patients had no cardiac risk factors. So they went on to do the third part of the study, which is in patients without established vascular disease. They said, let's calculate the Framingham risk score, which, as we know, is a risk predictor that tells you what your likelihood of developing coronary artery disease over the next 10-year period is. And lo and behold, what they found that a grand total of 1 patient was then categorized as low Framingham risk score. 30% of these patients were categorized as high risk. And let me just recap that high risk Framingham score is a greater than 20% chance of a 10-year risk of developing coronary artery disease. So truly a very, very high risk population that we're talking about here.